you. Assalamu alaikum. Good afternoon, everybody. I would like to thank panelists and organizer to invite me to present this case. Actually, this is a 52-year-old lady, a known case of diabetes, hypertension, dyslipidemia, and ischemic heart disease. The patient presented with the chest pain, admitted through emergency with acute coronary syndrome, non-STEMI. Angiography, actually, I could not download the full study of diagnostic angiography because of technical issue. Angiography showed RCA was normal, LAD, long and tight lesion, OM, high OM, and LCX. As we see here, there is a long lesion in LAD from proximal to mid-LAD. The case was discussed with cardiac surgery team in heart team meeting, and the patient accepted by them for CABG, but the patient refused. As we see here, there is a long lesion. This is fixed image, not movie, but I could not download the full videos. We did OCT of LAD, pre-PCI. As we see here, the MLA area around one square millimeter.
I think let's just pause here and go to the OCT again, because we would like to make it more education and interactive. So,
sure.
What is the finding that we're given out of the OCT?
What is?
Maybe the Wael will. OCT.
This is OCT Ultra. This was Ultron 2.0 OCT. So here we have it's a pullback from on the left side. It will be proximal and right side is distal. We have a very tight lesion, but I don't appreciate a lot of calcium, Dr. Ammar. In this OCT is mainly fibrotic or mixed plaque. So here we have a very good, here is subtotal occlusion with now no...
MLA area around one square millimeter.
Yes.
Or less than.
Okay.
Okay, it was.
Anyway, it's a long lesion with subtotal occlusion, but it's mainly fibrotic.
Fibrotic, yes.
Yeah.
So it was decided to directly stent LAD. We deployed the first stent from mid to distal LAD with the drug-eluting stent 2.5 and 48 deployed in the mid to distal LAD.
What was the size of stent again? The stent.
2.5, 48. There was no...
Why direct stent?
There was no calcium in OCT,
Well,
and
I think I could dispute this because while describing it as subtotal occlusion, of course you have a very tight lesion, so the contrast is not going to go through when you put the catheter in, so it becomes very difficult to assess. And with the fibrotic tissue, particularly in mid-LAD, quite often you have a lot of recoil.
yes, I
You might get away with it, obviously, but just to make sure that sometimes cutting balloon is the best thing for these lesions to prepare them, then you could put a stent or drug-eluting balloon.
Yes, that was the decision of operator. Okay, I agree with you.
To be fair with the Ammar, he's not the operator, he's just jumping in to present the case. So it's
No, no, it's not about criticism, it's about education for
No, no
everyone.
problem,
It's
no
absolutely, you know, just that, because we all do different things. You ask 3 cardiologists for opinion, you get 4. Everybody does something different.
Sure.
But I think just to go back here, I think it's
Yes.
using OCT. It's very important. In this case, it's very long lesion. You have to understand the type of lesion that you are dealing with and the length. We already have an OCT that proves there is a lot of almost subtotal occlusion and multiple area of deceased. There is not much calcium. And I think with this subtotal occlusion, we already know the size of the stent that we need, and preparation of the vessel before you stent is very important.
Yes, I think that here also we have to emphasize when we are using OCT, we have the MLD. What we do in the stenting or pre-PCI run of OCT, we measure the M is morphology. So here is it's mainly fibrotic, but a mixed plat in some areas, and length and diameter. And accordingly, we plan our PCI strategy. I totally agree with Dr. Mohanad also that cutting balloon would have been a very good choice, but still it's not wrong to go direct stenting.
Yes. The second stent deployed overlapping the first stent from mid to proximal LAD, and we deployed 3O, a 28 drug-eluting stent, overlapping the first stent. We actually some post-dilatation done with the stent balloon itself, not with NC balloon, with the stent balloon itself. This is a post-dilatation with the stent balloon. After that, we repeat OCT. And as we see here, especially in the mid and the distal segment of the stent, there was a significant lesion, fibrotic lesion. Here we can recognize.
Can we run the OCT? OCT is a post-OCT because it's
Abbreviation that you use for the post
it's the max.
max. So remember MLD and max. MLD for pre and max for post.
So in the post, we check the edge dissections, the stent expansion, malappositions, and this the max. But here, for sure, there will be under expansion stent in this area. See? Very under expanded, and there's a lot of artifacts, a lot of blood.
Here,
Okay, can you run it more?
OCT post-procedure showed the stent there is under-expanded, especially in the distal part, distal and mid part. As we see here, expansion in the orange color, it's 68. And also...
So usually expansion is not accepted less than 80%. Yani this is the standard for, and you can change on the software itself for your each user. For me, I put it like 90%.
Usually above 90.
Yes, for it should be like that. But,
Ideally, should be more than 90. Less than 80 is not. Conclusion out of the OCT here.
The second step after OCT, we repeated post-dilatation with NC balloon. NC balloon we did post-dilatation with NC balloon 3O.
yes.
From distal to mid and then to proximal. Proximal at high pressure, 3O balloon at high pressure, deployed at high pressure.
So I think that, as Dr. Mohanad mentioned, because the lesion usually subtotal occlusions, the contrast doesn't reach the distal area, so you undersize. So there is a tip here. You can inject from the side arm during the pullback, so you can get the proper sizing in the distal area. So from the start, the 2.5 was undersizing, in my opinion.
Yes. This post-PCI angiography, final angiography post-PCI to LAD. This is the final result. As we see here, there is also tight lesion in Ramos or high OM. There is tight and long lesion. So the patient was planned for staged PCI. The patient discharged in good general condition, and then the patient readmitted next week as electively for staged PCI to OM or high OM.
Again, we should pause again before we reach to OM. So now we have already an LED that diffuses. A lot of points have been learned from a strategy of fixing the LED. OCT done before, there is no preparation. Understanding the morphology was very important. Let's go to the basic of OCT. You already mentioned the abbreviation that we should go for, MLD and MAX. In morphology, they are always talking about low attenuation, high attenuation, how you can differentiate in OCT thrombus versus calcium, intraluminal or outraluminal.
So it's low attenuation. Both of them in a thrombus and calcium, they're low attenuation. But with the thrombus, because it absorbs all the ultraviolet rays, so you cannot see beyond the thrombus. In calcium, you can see, you can identify exactly the calcium, and you can get the depth of the calcium, and that's what the superiority of OCT over IVUS in the calcium, that you can get the depth of the calcium. This is how we can differentiate between a thrombus or a high lipid profile lesion, lipid core lesion versus a calcific.
Great. So Mohammed, you already started this, and we'll go back to you. So it's, other than pre-dilatation, any other point you want to make in this approach in the LED?
No, I mean, I think preparing the lesion is quite important. When you saw the fibrotic tissue, and we've seen this many times, the recoil and the expansion of the stent is always very difficult. And this is where one of the areas that I would use cutting balloon, because you could score that area, then you're able to dilate it. One thing about the OCT, and I still don't understand how, and it's all because of the resolution, you always undersize the size of the artery. Even looking angiographically, that proximal LED looks a 4. But the OCT looks quite okay, because it's that you only see the lumen very well, you don't see the whole artery. And it's well documented with OCT, you always try to go 0.5 millimeter bigger. With IVUS, you go a little bit lower, because it always gives you a bigger size. Basically, maybe again in these cases, maybe a drug-eluting balloon distal LED might have been an option, and that's again over the years has been shown to give a very good result, an outcome. Proximal stent if you need to, and then distally drug-eluting balloon.
Also, it's other option. Also.
So I think, Dr. Mohanad, about the undersizing with OCT, because it's usually if you just depend on the software to give you the size, you might undersize. But if you do it like media to media, as you do it with IVUS, then you will get a proper sizing, or it's usually 0.5 above the luminal diameter. If you don't want to, if you have the external elastic lamina is not very clear.
Just you touched now by Dr. Mohanad, the point, that area, especially that area where the lima will come in the future, I prefer to avoid metal in that area. Whatever you do, avoid to put metal there, and treat with DCB these days is better, especially in patients with multivessel disease.
I think DCB is coming a bit more recently in our business in the cath lab, and a lot of people pushing for DCB to think that you are not used to. Traditionally, it was instant restenosis, osteal diagonal, normal LAD. Now they say small vessel native, and even people, they do it with the non-STEMI, mid-LAD, mid-circ, and even some people stretch their business to proximal LAD. And Dr. Abdullah Shahab already talked to me once that he already did it for a STEMI.
Yes.
So who in this room think that in these cases, which we see it a lot, that the LAD is blocked from proximal to distal, that you only stent the proximal and leave the mid to distal for DCB without touching it for possible CABG in the future? So show of hand.
I have a comment, Dr. Fawaz.
We'll come to it.
Just to say, it's not because of future cabbage. When I'm going to do angioplasty, I'm going to try to do my best to get the best outcome, not thinking about cabbage. Because don't forget, the Lima attrition rate is up to 9%. So let's not forget that. You could have a Lima, but the attrition rate in the latest data that's come out, there's many studies now, but the latest 8.8% attrition rate of Lima. So it's not the perfect thing. But yes, a drug-eluting balloon, there's a lot of studies ongoing right now, some of them in CTOs. You open the CTO and you use the drug-eluting balloon, and even in acute MI. The only thing with acute MI is we don't know about the absorption of the drug through the thrombus. That's still, and so there's an ongoing study right now recruiting with acute MI to see whether the drug-eluting balloon will give you a good outcome.
I'm not going to change the topic, but what make you stent if you believe in that? What make you stent the lesion? You believe in that DCB is...
Yes, thank you. This is absolutely important because all of us have been trained to see that perfect angiographic appearance, the cosmetic effect. You have to learn when you're using drug-eluting balloon, that's not going to be the case. It's the functionality and the flow in the artery. It's not going to look perfect. As long as it's functional and the blood of TIMI3 flow, the outcome is very good. And there has been multiple publications so far on drug-eluting balloon, and all showing very good result. Now, there's a center in the UK that has been using this for many years, and they published this series recently in all the cases, and the acute vessel closure less than 1%. So it's that mental kind of prep, or that's how we're used to. You have to see that perfect appearance with the stent, and this is what we need to get away from.
Dr. Colombo wants to present to us this, and you already have an algorithm. It's not about just doing a DCB and finish. He always starts with FFR and end up with the FFR. And there is an algorithm with it. If the FFR at the end more than 90, he will stop. If there is no dissection, he will stop. And there is a specific criteria when you move from DCB to drug-eluting stent. So I think it's just to complete it. If you want to just go on that path of a DCB, you should have a specific algorithm, identify your patient, and identify the minute that you should go for stenting on each lesion.
I think that also, before using the DCB, we can do NC balloon or just simple PCA and see how the vessel reacts. If the vessel is, I'm having very good result with PCA, just BOBA, I will go to drug-eluting balloon, and I know, but if I have a dissection or like Dr. Fawaz have mentioned, they use the PDPA. Dr. Colombo have suggested this algorithm, and you have a PD of more than 90.9, then you can leave it.
Come back to you.
Okay. So next week we brought the patient for elective staged PCI to OM. Actually, initially we tried with OCT to high OM, but the OCT catheter could not cross the lesion, as we see here. So it was decided to do balloon angioplasty with the smallest balloon. Even the smallest balloon, we could not cross the lesion. This is attempt of balloon angioplasty to high OM. Even small balloon, we could not cross with a small balloon. So it was decided to do orbital atherectomy. We insert guide wire in LAD because yes, the guide catheter was not stable. It's GL.
Lesion itself is uncrossable lesion. And what's next?
Next, we did five runs of orbital atherectomy at speed 80.
Let's can go. Yani, why did you choose speed 80 here?
This is not me. It was not me, the operator.
So let's, because I know also Dr. Muhammad is one of the very good users of CSI, orbital atherectomy. So in vessels less than 3O, usually we go
Larger
with
vessel.
an 80,000. And in such lesion, if you can cross, and I know this what happened in this case, they've done a retro grade atherectomy. They crossed with a glide, and then they've done retro. And in these cases, with this kind of guide support, if you can do this, it will give you more better results. And also in tortuous anatomy for aorto-osteal lesions, this is a privilege of CSI. And you know the bear is only we have one bear. It's 1.25, and it can treat diameters from as IFU from Abbott is from 2.5 to 4. But we have used it in 2.0 vessels and up to 4.5. It can work. Not very effective, but it gives nice results. And it for nodular calcific nodules, it have a superiority over other the rota and the shock wave.
Did a lot of while in uncrossable. Start with it.
Yes, it is the indication. There's an algorithm for calcific lesions. So if you have calcium and geography, then you go with your IVOS or OCT. If it's uncrossable,
this is
then
undilated. There's a difference between undilatable lesion and crossable lesion. So you cannot cross it with anything. 1.2, even 1 millimeter balloon doesn't cross that lesion.
This is laser. If you want to do the indication in this, if you can cross with a rota wire, then you can do rota. Laser is, I prefer laser in this kind of lesions. But here it was uncrossable because of calcium. And according to the algorithm, you go to rota or CSI. And CSI can give a very good result in these cases.
So I would like to disagree because here you have uncrossable lesion with a balloon, right? We know CSI is not a frontal cutting. So if you have, you need atherectomy, rota is a frontal cutting. So if you have a lesion that's tight, you cannot cross a balloon with it. My choice would not be to go for CSI right away. And I wouldn't do CSI in a small vessel like this. I think that vessel is too small for CSI. Plus, not having a good supportive guide, I would be more worried doing atherectomy and using an atherectomy device with this guide, to be honest with you. So just to clarify, because with CSI, where you're doing the ablation is actually 6 millimeter behind the tip of the crown. So it may have worked for you here, but if you have a lesion that you cannot cross, probably a frontal cutting device will be a better option. Laser may be an option. You can anchor with the new stent if you want, change your guide, have a bigger guide. And then we can talk about OCT and calcifications.
Yes.
Thank you.
And I think that's a great algorithm. So in this case, you wire it, you cannot cross it. The first thing you should do is change the guide. Have a better guide and try again. If you cannot cross it, you go with the rotablation. Maybe CSI, I will use, in my book, I'll use it with undilatable lesion that I already crossed it with the balloon. But if I cannot cross anything, CSI is not my first option.
So,
I have more time.
Akazia,
Disturb his time.
we finished our time.
So extra 5 minutes. We just want to make it more interactive than presentation. So that's what you're going to learn from.
This is post-orbital atherectomy. The balloon easily crossed. Then
also mandatory to do post atherectomy, both rotor, to do an NC balloon and see if the lesion is or no before putting your stent.
we did compliance
Excuse me,
balloon
just to, since you have the OCT didn't cross the first place, right? So that would have been, and you decide to do atherectomy. It would have been a great case to do OCT after to see calcium fracture. We know that OCT is great for calcium. The difference between OC and IVUS just blurs the calcium behind it. So you cannot quantify the amount of calcium. With the OCT, you know if you have more than 0.5 millimeter depth, if you have more than 5 millimeters length of calcium, and if you have more than 180 degrees, your chance of having a stent that's underexpanded is more than 25%. So in this case, if you already had the OCT catheter on the table, you did CSI, even before you take the balloon up to see if you need to do more atherectomy. The problem with the CSI sometimes is the feedback is, okay, I've done CSI. It takes a lot of experience and doing a lot to know when is enough atherectomy. Because the worst thing is you do atherectomy, you take up the balloon, and it's not expanding. With rota, with the deceleration, the sound of the rota, how the burr goes, maybe it gives you more tactile feedback for the operator to kind of get an idea, did I ablate enough or no? So this will be a great case to do OCT after you have done CSI and see how much, if you have calcium, how much, is it fractured or no? There's good studies from South Korea about the amount of calcium calcifications and how good of a stent expansion you would get. So
Okay.
there's that score of 4.
We can leave the discussion after the case, please. Dr.
Yeah, I would like to say something. I would like really to give Dr. Ammar a chance to present his case. Please give him a chance to present the case and see his result.
We're planning to do that.
I agree with you that you have so many options, you are more experienced, but give him, let him present his case. Let him show the result.
Dr. Jassim.
I'm sure all
Dr. Jassim,
options were discussed in the cath lab.
Dr. Jassim, you are biased. You are same hospital. ما يصير تكلم.
We'll continue the case.
Post-orbital atherectomy, we did balloon angioplasty with NC balloon 2.0, and then finished with drug-eluting balloon. This drug-eluting balloon deployed distally, and then another drug-eluting balloon 2.0, 20, inflated proximal high OM. We did OCT post-procedure, post-angioplasty. It's acceptable result.
Yeah. Come to the end, then we'll ask Dr. Jassim to comment on that.
And this is a final angiography. Thank you for your attention.